Hello, my name is Tim Walsh. I'm based in Edinburgh in Scotland, and I'm going to speak about anemia after intensive care discharge and the possible implications for our intensive care survivors. Here's my conflicts of interest slide. None of them are relevant to this presentation. They're all managed through my university. I am chief investigator for the ABC post-intensive care trial, which is a relevant trial to this publication, to this presentation, which is funded by the Moulton Foundation through the University of Edinburgh. So the context here is that anemia is prevalent during intensive care stay. We all recognise that. And we know from a number of key studies and systematic reviews of studies and guidelines that restrictive transfusion practice during intensive care stays evidence-based and associated with good outcomes compared to more liberal practice. And from that, our guidelines tell us that our default transfusion trigger should be 7 grams per litre, and that our trigger should be in the range of 70 to 90, with adjustment made on the basis of some patient comorbidities such as heart disease and clinical judgment. As a result of this, many of our patients are anemic at the time we discharge them from the intensive care unit. So this is quite an old study that we carried out in our region some years ago, just to look at that prevalence when restrictive transfusion practice was carried out in intensive care. And I highlight in red at the bottom that in this cohort of typical general intensive care survivors, we saw a last hemoglobin in intensive care at the time we discharged the patients of 9 or less in around about a quarter of all patients when we apply restrictive transfusion practice. Now, if we look at the WHO grading of the severity of anemia, which I lay out on this slide, you'll see that that essentially means that about a quarter of our patients we're discharging with what the WHO would term moderate to severe anemia, which is a sobering thought in terms of survivorship and the ongoing care and management of these patients. And we're aware that the symptoms of anemia that are well known to the public, this is just from a Google image from Googling anemia symptoms, include chest pain, cardiovascular problems, fainting, dizziness, fatigue, and breathlessness, all of which we know can be prevalent among our intensive care survivors. And when we ask our survivors what are the most important symptoms to them, it is fatigue and weakness. And this is taken from a small qualitative study carried out with intensive care survivors that asked them to rate the most important symptoms to them. And I show in the red rectangle that the top 2 were lack of physical strength and fatigue, rated as prevalent and most important to them. So our patients have symptoms that might be related to anemia, although we don't know whether that's a causation or association. So what happens to anemia after patients leave ICU? And this is another study we did now some years ago, where we followed a reasonably large cohort of general intensive care patients through until the time they were discharged from hospital. And you can see here, I've highlighted in red the proportions on the right-hand side, that around about a 30%, 1 in 3 of our patients are discharged from hospital with a hemoglobin less than 100 grams per litre, and slightly more than slightly less than 1 in 10, around about 1 in 8, are discharged with a hemoglobin less than 90, which is moderate to severe anemia in WHO terminology, with around 80% anemic compared to the reference range. In other studies, we've followed up patients for longer periods, and in this study, again, quite old data now, we followed up a group of anemic ICU survivors for up to 6 months, which is what we see on the x-axis in weeks on the bottom of this graph. And we plotted hemoglobin recovery over time in males and females and in the cohorts. And you'll see that in summary, at 13 weeks, so about 3 months, around about a third of patients still have significant anemia, less than 110 grams per litre. And even at 6 months, 16% had a hemoglobin less than 11 grams per litre. And these are levels, for example, in chronic renal failure, intervention would occur to correct anemia because that's associated with improved quality of life. So what might cause persisting anemia following ICU discharge? Well, we believe one of the main drivers is probably persisting inflammation. And if you have a persisting inflammatory response, you will see an increase in hepcidin production, and hepcidin is a key mediator of iron metabolism. You will also, and will reduce iron absorption from the gut and sequester iron into inflammatory cells and make it less available to erythropoietic cells in the bone marrow. Inflammation also blunts the erythropoietic response and reduces the erythropoietin levels, and it will redistribute iron and make it less available for new red cell production in what is called a functional iron deficiency. It may also be there is a true iron deficiency, and that may be partly mediated by hepcidin because that blocks iron absorption in the small bowel. But I also highlight that we probably don't look for anemia in our ICU survivors or actively evaluate and treat it, because we tend to think that anemia is acceptable in association with critical illness because of the evidence of restrictive practice being evidence-based, and yet we don't have evidence in the recovery period that this is the case. So how prevalent is anemia in ICU survivors? There are a number of studies looking at this using various inflammatory markers, most commonly C-reactive protein. And this is just one study, again, taken from our own work, where in our RECOVER trial, which was a randomized controlled trial of interventions to promote rehabilitation, not to do with anemia management, we looked at a cohort of ICU survivors at 3 months after discharge from ICU, where these patients were essentially all at home. And one of the evaluations we did was we measured inflammatory markers. And you can see here over on the right that in red, which is patients with significantly elevated CRP, not surprisingly, most have that at ICU discharge, but quite a high proportion at 3 months will still have a significantly elevated CRP or a moderately elevated CRP, and more than half of them will still have evidence of persisting inflammation. And this has been confirmed in a number of ICU follow-up studies. So patients have inflammation during recovery, and it may persist for some time. So what's the association between anemia and quality of life, which ultimately is one of the things is most important to us in our survivors? This is taken from the 6-month follow-up study I presented a few slides ago, and looked at the domains in the SF36 quality of life questionnaire. And what I've highlighted in the red rectangle here is the value in roll physical for the UK normal population, which on average would be about 76. At 3 months, a UK ICU non-selected cohort, so not those who were anemic, in which case it drops to about 47%, and we recognise that from much post-ICU follow-up work. But then I've quoted here what we saw reported in our cohort of anemic ICU survivors, where roll physical was significantly worse even than an unselected ICU recovery cohort, and much, much worse than the general population. And you'll see at 6 months, there's a similar pattern. Now, what we found in this study was that the strongest predictor we could find in what was a small study of failure for anemia to resolve and recover spontaneously was evidence of persisting inflammation during the post-ICU hospital stay and at later time points. This seemed to predict failure to recover, suggesting that an inflammatory anemia may well be important, and this may be associated with particularly poor quality of life. But again, we don't know if that association means causation. The other point I'd make is that the way we use blood transfusions during ICU stay and in the post-ICU period almost certainly strongly predicts the trajectory of anemia that we leave our patients on during recovery. So this is taken from another trial we did, which was a pilot feasibility trial of restrictive versus liberal transfusion practice in older patients who had a high incidence of comorbidity, including cardiovascular disease. And what the graph shows is the distribution in box and whisker plots of the hemoglobin values between the restrictive practice, where the trigger was 70, and the liberal practice, where the trigger was 90. And what I show on the right-hand side is the last day in hospital before hospital discharge for the patients in that study. And you see that there's a clear difference, that if we apply restrictive practice, we send people home on average with a hemoglobin of around about 8.5, whereas if we used a more liberal practice, it's closer to 10. So this is very clearly an important determinant of the exposure to anemia. Now, if we turn to iron deficiency, the interpretation of iron indices is really challenging in critical illness because of inflammation. But this is an interesting study by Lasocki's group, which showed that fatigue after ICU discharge is strongly associated with evidence of iron deficiency, even after you adjust for the presence of inflammatory markers, suggesting again that this might be an important determinant of fatigue and important symptomatology. So to summarize, anemia is prevalent among ICU survivors, and it persists for many weeks or months in some patients. And persisting inflammation plus possibly iron deficiency are the most likely etiology in these patients. Anemia is associated with particularly poor outcomes, but a causal relationship is uncertain until we do clinical trials specifically in this area. Potential therapies include post-ICU discharge transfusion strategy, in other words, being more liberal after ICU discharge, and we're about to start a trial called the ABC post-ICU trial to explore this in the UK. Iron therapy is another option, and again, there's a study in the UK called INTACT, and there may be others elsewhere that are beginning to explore this for ICU survivors. And the role of erythropoietin is as yet undefined in this cohort during later recovery. So we need ongoing and future trials to really define whether treating anemia in the post-ICU period might improve the outcomes for some of our patients. And this is the trial that we are about to start in the UK, which is specifically enrolling patients at the time of ICU discharge. And I'll thank you very much for your time. Thank you.